able to pick a non-positive one correctly, being able to pick a positive one is very, very important. Otherwise, when they missed out, there is risk of not treating a positive patient, and we know what that will lead to. Okay, so we are also looking at, when we look at diagnosis, we now look at rational drug use. When we talk about rational drug use, we start by looking at the quality of medication that we are using. Now, if you have the skills, you're able to choose the correct dose, you're able to choose the correct dosage, the timing and all that, but the quality of the particular medication being administered is questionable or is in contention, then it will also affect our target of eradicating malaria, because treatment will be impeded. So we also ran quickly, especially now that we have made artesunate injection. WHO has approved artesunate injection to be first-line treatment for complicated malaria. So we quickly ran a test looking at the available, like a post-market surveillance, available artesunate injections now used for complicated malaria, not even uncomplicated, complicated, which means is severe, is a kind of emergency, right? The patient is already being exposed to one form of organ challenge or damage or the other. Now, what did we find out? We find out, well, the study we carried out in Nigeria, we pulled different brands of artesunates from the south, from the east, from the west, from the north, from pharmaceutical shops, registered pharmaceutical shops, different companies. And when we ran a test, looking at their label claim, to see if they said 120, whether it is actually 120. So we noticed in Nigeria that 66.4% of the samples that we screened had lower label content, not up to. We observed that those ones that were of 60 milligrams, they complained more, but those ones of 120, they had lower content, and that was below the approved pharmacopoeia within the limits that pharmacopoeia has prescribed. Only 33.3, like about 1/3 of them, were within the limits that were to be accepted. And it was noticed that samples from the north had lower content compared to the other. The one from the west had, in fact, the samples that complied more were from the west, and they had higher content compared to the one from the north. Now, surprisingly, this particular trend repeated itself in a study, the same study carried out in Uganda. The samples coming from the northern Uganda also had lower quantity compared to the ones from their western region. Now, another study should confirm whether temperature has affected that or transportation or whatever, but we just looked at the content and compared it with the label claim, and this is what we found out. So for that of Uganda, you can see that 33.3%, but for Uganda, for Nigeria, it is this. And now the question is, how sure and how guaranteed is the quality of the medication that we have? We have other studies that by other authors that have also run quality check on tablets and all that, and you see deviations here and there. And the major concern is that this is artesunate injection for complicated malaria, for severe malaria. So a patient who is already presenting with complication and is receiving a medication that is lower than the content, we know the implication. There is risk of what? Low efficacy, because the patient is taking suboptimal dose of the medication where there is need to take the standard dose. Now, what of cost, the burden of treating malaria and the pattern of treatment? So you find out that our research showed that for you to treat malaria, Now, uncomplicated, look at the direct cost. What we mean by direct cost, looking at the cost of the medication, the laboratory test that the patient had to run. For you to treat an episode is about 2,234 naira for you to treat an episode. And we've noticed again that in the pattern, you find out that 62.4% of the patient treated for uncomplicated malaria received injection. This is not in compliance with WHO recommendation. The WHO recommendation, when you carry out in a population, it should be less than 30, because that's even that 30 is in case there are other needs that the patient actually needs. But 62.4 of the population being on injection when they are being treated on uncomplicated malaria is out, not in agreement with WHO recommendation. And about 70 of them were on antibiotics, right? And it is only where they complied is in the issue of using IV artesunates for initial treatment for patients that had complicated malaria. That one they complied. So noticing this, you find out that even in the prescription, there is still concern, right? Now we look at, try to audit artemisinin dosing. Now artemisinin combination or derivatives are like the benchmark, the hope for treating and eradicating malaria currently. And we looked at e-dosing, auditing e-dosing. And we looked at different secondary hospitals within Enugu State, secondary hospitals. So what did we find out? Most of the prescription did not comply, about 57.3, did not comply with what? The WHO guideline with respect to pill burden, antibiotic, dosing regimen, and all that. Okay? Now, it might interest you to know that when we say that we audited the dosing, for artemisinin injection, we have artesunate. We audited artesunate. We audited artemether injection, artesunate injection, artemether injection, and alpha beta artemether. Surprisingly, we found for artesunate injection 4 different dose regimens being used in hospitals. We used secondary hospitals, 4 different regimens, and for artemether injection, 3 different regimens, and for alpha beta artemether, 3. Now the question is, why is there no compliance? Like artesunate injection, we have WHO has recommended 2.4 milligram per kg at 0, 12, and 24 hours, then switch over to oral. For adults, then children, 3 milligram per kg for at 0, 12, and 24 hours. But in our research, we find out that some institution or some hospital, they were given, okay, the correct one, 2.4 milligram at 0 days a day. Then some will give 120 milligram BD for 2 days. Some will give 120 milligram starts and switch over to oral. Some will give 2.4 milligram per kg starts and switch over to oral. So these are different varieties with their, each one has its own clinical implication. So it was noticed that most of the dosing were not based on weight. Meanwhile, artesunate regimen is highly dependent on weight. Weight needs, but they were not referring to weight. So these are some of the things when we talk about eradication, we look into this thing, because once even treatment of those that have been infected are not being guaranteed, then eradication might be a challenge. So we look into that. Now, again, we are looking into when we have what we have like, what do I call it? Reservoir. So you see what we have now, being able to dose and being able not to dose. We also looked at, because if you talk about malaria, it's being transmitted. The plasmodium had to bite, right? And we know the life cycle, and it is transmitted through when the female Anopheles mosquito is feeding and all that. So there is transmission. However, for a mosquito to be able to treat it, the mosquito must be infected, which means the mosquito has bitten an infected patient. For the mosquito to have picked up this particular plasmodium and move on to go and infect another. So we try to look at asymptomatic percentage of asymptomatic malaria in children. And we found out that when we screen children in primary schools, right? Children in primary school to look at presence of symptoms, but do they have parasthenia? So what we did was just to withdraw blood sample from students after getting ethical clearance that have not presented and will get consent from their parents. Is your child sick? No. Fever? No. Being in hospital? No. Then we pick. And we noticed that 24% of the children were not asymptomatic but had parasthenia already, meaning that even though they are not symptomatic, they are what? They are already like a reservoir, because if bitten by a mosquito, then the transmission can continue from there. They're already like reservoir, meaning that even for this group of patients, they also need what? Prophylactic treatment. But because they are not tested, they don't know, they'll just be moving. And before you know it, if the immune system goes down or the child is stressed or whatever, the next thing you see is a full-blown malaria case. And the parents or whoever involved will be surprised that yesterday this child was fine, but today he's having this level of fever and all that. And of these patients, 45.8 of them were already anemic. Were anemic, even though they have not started presenting. So it means that even while we talk about treatment of people that are symptomatic, there is also need to look at people that are not symptomatic but could be what? Reservoir, or could need prophylactic treatment. We are still looking at what we have on ground with respect to rational treatment, so that when we go on to discuss about our actions for the eradication, we know where to place our game. So we also looked at access of malaria treatment among pregnant mothers. And we are seeing that of the pregnant mothers, 72.4 had access to IPT, intermittent preventive treatment at their ANC. But we should have it at 100, because the other 20-something% that does not have access are already what? Vulnerable. This is access to their prophylactic malaria treatment. Only 44 had access in Enugu, where we did the intervention. Now, we are bringing up this. This could be, yes, it's in an area, but it could replicate or give an idea of what is also happening in other areas. Only 44.4 had access to what? ITN. And remember, we are looking at eradication. If there is eradication, you also talk about prevention of what? Getting the disease, which ITN is one of them. And about 75.1 were able to have their malaria managed, treated in the hospital. Okay. Now, we have drug resistance and adherence. Because when we talk about eradication, we should also look at challenges. What could be a problem to the eradication of malaria? We looked at the options, and remember we had research, supporting research. So what the new research are looking at now, are looking at drug resistance, what could be causing it, which area are they coming, what are the parasites doing, what is the plasmodium doing to avert the effects of the medication of drugs on them. So research has shown that this plasmodium, there are gene markers that are already associated with what? Anti-malaria resistance. So we are looking at the ones that are affecting ACTs. We have chloroquine, we have PCT resistant, but then because chloroquine, though is still being used, but it's no longer first line, so most attention is not probably on them. But Plasmodium falciparum multi-drug resistant gene is a gene, a mutation in the Plasmodium that has been found to be associated with what? Resistance or treatment failure. So we carried out a research to screen for these alleles, whether they are there. We found them in patients. So we screened patients that have malaria coming to hospital, we sampled them and we screened them. So at the end, they all were on ACTs, acetaminophen to be specific. And all of them had their 3 days treatment. Then after, we looked at the ones that had parastemia clearance, complete clearance within 3 days, and before they finished the treatment, there was no symptom. And we had some that were free of symptom, they are no longer presenting okay, but some had to come back with complaint. So we had to go further to screen and see if we can see this particular Plasmodium falciparum multi-drug resistant gene among these patients. So we screened both the ones that had complete treatment, therapeutic outcome, good outcome, and the one that had presented with symptoms. And we noticed that among the patients that had what? Post-ACT treatment symptoms, that they had more of what? The Plasmodium falciparum multi-drug resistant gene. This gene was more in them, meaning that we should also look out for this particular gene. We have Plasmodium falciparum multi-drug resistant gene, and we have Plasmodium falciparum kappa 13 gene. Now, the kappa 13 gene has also been identified to be associated with malaria resistance. However, this gene we screen and other studies have confirmed is not prevalent in Nigeria like the multi-drug resistant. So this other one is still few, had less impact, but multi-drug resistant gene, they have it more and is associated with drug resistant. Patients with this resistant allele resist, their outcome to malaria treatment is not as desired. Okay. Now, we tried also to look at, because counseling and education is part of the step we take in eradication, we try to look at adherence to medication, knowledge. What do people know? What do patients know about? Do they even know that they could be malaria resistant? Because people are more acquainted to antibiotic resistance. Let's know if they even know. And when they have this medication, if they finish it. So this one is not laboratory, it's like a survey, finding out what people think and what they know about adherence and so, and we noticed that 77% of the people were sampled when they they're placed on anti-malaria medication took the complete course. 23% were not adherent, did not complete. And most of the time, what their reason for not completing it is that once they felt better. Why? Because ACT, artesunate, artemisinin derivative, they have rapid clearance potential, very, very rapid, right? So immediately you're taking it, within the first day, 24 hours to take it, there should be rapid parastemia clearance. So once this happens, patients tend to feel better. And this is a major reason why they do what? They tend to leave this medication. So we find out that there is need to do what? Look into their adherence. Now, what is now the tools? What are we looking at? So when we talk about eradication, there are already steps on board like vaccines. So now is a historic milestone that is being achieved, though not globally, but serious research has been ongoing. So when we are talking about eradication now in the aspect of prevention, not treatment now, then we go into vaccines. And we have this ASO1. This is basically very high immune system boosting vaccine for children. And we have the R21. So when you combine for prevention, vaccines, intermittent treated nets, and when you have your chemo preventive, prophylactic medication, this has the potential to give us more than 90% eradication or clearance or prevention from malaria disease. So when we talk about prevention now, going into what we are doing, you have this dual insecticide treated nets. When we have to combat the parasites with double from what is it called, from two angles, so that we are able to overcome its ability to resist the chemicals in the treatment net, so that the parasites will not be able to do what? Have access to biting the patient. Now, an interesting area is the gene vector control area. Okay, let me just say a bit about it. So now, an area for eradication, which I know that when we go into it, is going to help. It requires research, it requires support, is this area of one, gene drive technology and partial talents. This particular technology, it is going to help to do what? Generate or breed parasites that are not able to do what? Transmit malaria. So they have the goal of this particular gene technology is to suppress mosquito population or make mosquitoes unable to transmit malaria. That's basically what is all about. Then these things are targeted, the gene technology are targeted towards the malaria, while the repellents are targeted towards the parasite, while the repellents are targeted towards its entrance into the individuals that are prone to the disease. Now, when we look at the emerging threats, like I've mentioned, artemisinin resistance, Plasmodium falciparum, HPR2 deletion, because why this particular histidine-rich protein 2 deletion is very, very important. Our research here should look into this, because RDT is effective by detecting this particular histidine-rich protein. But now mutation in Plasmodium, they now mutate to delete this particular gene that RDT detects. And this is part of why its sensitivity is becoming very, very low, right? So it's a very important area. And we have Anopheles stephensi. This is a new resistant gene that is also upcoming. I'm a bit rushing. Then we have some standards. So now, what is the role of pharmacists when we talk about this elimination? Then there is anti-malaria stewardship, right? There's diagnostic and quality advocacy and community engagement. In anti-malaria stewardship, we'll be looking at rational use of malaria. Now, we have also researched on self-medication. We find out that people use anti-malaria with antibiotics and all that, and will not complete those. But now, when we talk of stewardship, we, the pharmacists, most time we administer this medication. Most people with malaria don't visit the hospital, they visit the pharmacy, community pharmacies, or even do a call. And so we need to monitor this. So it means we have to go into diagnostic, quality medication, and monitoring what they are taking and how they take it. And that will lead us to the next slide, where I just looked into common drug-drug interaction and drug-food interaction that occur with anti-malaria medication. So you have a patient probably that has is on carbamazepine or rifampicin or this. These are potent enzyme inducer. This particular medication, the enzyme that they induce, unfortunately, is responsible for what? Metabolism of ACTs. And what they do, if they're taken together, they will increase its metabolism, and there will be low serum concentration or blood concentration of ACT, and it will lead to treatment failure. Likewise, I've just displayed them here. So you have your ketoconazole. This one, lumefantrine, that is in combination with artemether. Lumefantrine has what? Potential for QT prolongation. And ketoconazole also has it. So it will increase that potential and all that. So we see how interaction with this medication, anti-malaria and other medications, some medication will reduce their efficacy, some will increase and others. So as clinical pharmacists, our role, very, very important, is to do what? Anti-malaria stewardship, look at this, find out this drug-drug interaction, know them, and we do that. Then there are food that also interact. Now, when you talk about absorption, you cannot overemphasize the need for what? Fatty milk, your meal or your milk or fatty milk when you're taking artemether. But most time, we don't emphasize on it, but this is needed, very, very important for you to do what? For absorption to increase. Meanwhile, if a patient is taking artemether without fatty meal, there is possibility of, you can see, fatty meal increases the absorption by 16-fold. So not taking it, there is possibility of absorption to be by half, and this will affect the what? The CMAS that leads us to the response that we want. So you see atovaquone and proguanil that's mostly taken for prophylaxis and all that, even doxycycline. And because doxycycline most time is used for prophylaxis. So these are common drug-drug interaction that occur. Now, talking about our role again, remember we looked at counseling. It is very important that some medication error will be overcome. When there is medication error, most of the time it comes from the pharmacist, because even after prescribing, we are the one to dispense. So medication must be by weight. ACT, it should be dosed by weight. Most of the time, they are not dosed by weight. Now, wrong number of tablets per dose. Then, very, very important, counseling error that are missing, like incorrect dosing. Artemether lumefantrine is taken at 0 hour, then after 8 hours. This particular after 8 hours is a rate-limiting step for efficacy of artemether, because it has short half-life and it has rapid clearance. It needs that repeated dose after 8 hours for it to complete that rapid clearance. But most of the time, we administer this medication and still write 1 by 2. It's not 1 by 2, it's 1 starts, then after 8 hours, before you now go into morning PD. So, and this counseling, we need to take it seriously, talk about repeating dose. Now, in our research, we find out that most patients vomit artemether, ACTs, because it has a bit of nauseating dosing. So we should mention it while we are administering. Please, if you vomit, repeat the dose and all that. Now, again, in pregnancy, we should be asking patients whether they are pregnant or not, because this medication, most of them are contraindicated in first trimester. Now, we can. Now, we must. So what do? You have to scale up vaccine delivery. Now, this vaccine delivery, we have not had it in Nigeria, but the research is serious. So there is need to support research. This one comes to the research body, policy-making body, government support research, so that we can have this. Vaccine is what will more give us a higher percentage guarantee of what? Eradication. Strengthen our molecular research. Fix drug quality issue. Most of our drug, we need to carry out post-market surveillance. Most of our drugs are not the labeled claim. We have to invest in pharmacist-led community malaria management and be very, very consistent with dosing. And we have to screen to find out asymptomatic cases and measure up. When we have issues like in vaccine ITC, we find them out. And now, message of hope. When we enumerate all the challenges we are having, it will not be as if to say we cannot eradicate malaria. Oh, we can. Because in the past, we have diseases that, came and lasted, but we did what? We overcame. We had smallpox before, by 1980 was eradicated. Even wild polio virus, as at 2015, we eradicated type 2, 2019, type 3. So it is possible to eradicate what? Malaria. It is possible in Nigeria. So there is hope. If we go into all that we have mentioned, looking at correct diagnosis, looking at our ACT, again, knowing that there is possibility of ACT not picking positive cases, especially when there is low parastemia, and looking at researches that can develop ACT that is not picking Plasmodium histidine-rich protein because the gene is already deleting it. develop another one that has a key ability to detect with another, the current one, then that will be done. Then
Sorry to
tools
cut
that
in,
are
Prof.
now.
Prof, sorry to cut in. Please, can you try to round up? We have another speaker
Okay,
waiting, and time
okay,
is not on our
30
side.
seconds. 30
Okay.
seconds.
Thank
All
you,
right,
ma.
so using the new tools available, we're able to achieve it. Then when we now have become responsible for all that we have said, drug this thing, then we'll be able to do it. Malaria is possible to eradicate it. Yes, we can, and now is the time. Thank you so much.
Wow, thank you very, very much, Dr. Ayogu. It's so educating and it's very enlightening. Thank you so much. I think we'll call on the next speaker, and then we'll have the question and answer session together. Or Dr. Muni, what do you think we should do? Or should we just have a section, question and answer now?
I would think maybe we should just take the second presentation.
Okay. Thank you. Okay, so I will now call on the second speaker, Dr. Pharmacist Oladapo Olushefumi. He's the product manager at Pharma Biosys Nigeria Limited, and he's going to talk on the topic multiple first-line therapy, strategic approach in the treatment of uncomplicated malaria, a key recommendation from World Health Organization. So, Pharmacist Oladapo Oluwashefumi, you have the floor, please. 30 minutes, please. We don't have much time.
Hello, please, Pharmacist Adetutu.
Yes,
Hello.
please. Hello, I can
Please,
hear you.
okay, I want to find out from Pharmacist Emmanuel. You mentioned you dropped form for attendance. I've not seen anything, so I don't know. Have you changed your mind?
Yes,
Pharmacist,
yes, good evening. Yes, Pharmacist Emmanuel will post the link in the chat room shortly.
thank
So
you.
just give us the next few minutes. Thank you so much. I know we have 100 people here, so we would like to capture this audience. I would like to share my screen as well. And please just confirm when you can see my screen. Sorry. Please, can you see my screen?
Yes, you can see your screen.
All right. All right. All right. Good evening, and I'm going to be standing on existing protocol. It's a privilege to be speaking to all our distinguished pharmacists here present. My name is Oladapo Shefumi. I'm a pharmacist, and I work as a product manager at Pharmacy Biosys. Our company, our mission is delivering healthcare solutions that fit the needs of the African populace and focus here Nigerian citizens. And the topic today simply is multiple first-line therapy, a strategic approach in the treatment of uncomplicated malaria, which is a key recommendation from the World Health Organization. I'm going to just dive into it and maybe just to also appreciate our first speaker, Dr. Emilia. That was a wonderful presentation, and she's already taking a lot of the burden tonight because there's so many things that I wanted to say, but she has shared it already. This is my outline, looking at the burden, just a top-line view. We'll look at anti-malarial resistance. What does it mean? What are the different nuances to it? We'll look at WHO strategy, the multiple first-line therapy, really understanding what that strategy means and what value it can give in our fights against malaria. We'll look at the rationale for Nigeria. We'll look a little bit at pediatric anti-malarial therapy, and we'll also look at one of the newest ACTs that have been introduced into the Nigerian treatment guidelines as recommended by the World Health Organization. All right, the first picture you see here is a picture of two people that are fighting a battle. The big question is, what war is going on? This is not the war between Iran and the US or the war on the Strait of Hormuz, but this is the war against malaria. And the question is, are we really winning that war? Dr. Emilia has already done a lot of conversations around the global burden, which is currently at 282 million as of 2024. And we still see an increasing number of malaria-related deaths. I mean, we're looking at 12,000 increase over the space of 1 year. So, I mean, 12,000 people, this could be anybody that walks up into your pharmacy or someone you meet on the road. People are still dying from malaria, and this is our reality. This is just a picture speaking to, the cases that we have, right? I'm trying to see how I can take this out of here. Just a second, please. So we can all see it. Please just give me a second. Yes. All right. Just trying to figure this out. All right, let me just continue, right? So this is the distribution. Yes. So this is the distribution. All right. Yes. Thank you. So this is the distribution of global malaria cases, and Nigeria still has the highest number of cases at 24.3, and also the highest number of deaths as well, right? And these are things that we have seen, in the slides. Now, speaking to the burden, as of 2024, we are at 68.4 million cases versus 2023, where we were at 68.1 million cases. Now, the reality is, are we really winning the war against malaria? Right? We have so many things that we have discussed tonight: resistance, treatment failure. At this point, we need to ask ourselves the real question. The solutions we have, the approach we have, the strategy we have, is it really addressing the fight against malaria? Are we really winning the war? Now, WHO keeps an eye on current anti-malaria resistance, and I also see, and I'm very encouraged to see that even at the country level, there is active research going on tracking resistance. I mean, we've seen some of the studies from tonight from Dr. Ayogo, right? Anti-malaria resistance, we're seeing malaria parasites with P. falciparum histidine-rich protein 2 gene deletions in 42 countries as of 2024. Right, and these parasites with this strain in particular undermine the accuracy of the RDTs that target the histidine-rich protein 2 antigen, and this means that patients that are infected with these parasites, they will not be detected by these RDTs, and this is worrisome because a lot of patients are being tested with RDTs in the country. So what would be the outcome if they are infected with this strain of the parasite? This is a threat map for treatment failure, right? Showing incidences of treatment failure across sub-Saharan Africa. And we are assessing the 3 of the first-line antimalarials that are currently recommended by WHO. Now, this study was done by WHO. Artemether lumefantrine, of course, the most used ACT as of today, shows tremendous number of treatment failure cases. I'm sure you can see my pointer, right? Now, if you look at dihydroartemisinin
Mute yourself.
Okay, thank you for
You
muting.
can stop if you're not speaking. Please, can everybody mute? Please, let's mute so I can listen to the facilitator. Thank you.
Thank you very much. Now, I was just showing this slide speaking to incidences of treatment failure as tracked by the WHO, and we can see the dense spread of incidences of treatment failure across Sub-Saharan Africa to artemether lumefantrine. If we look at dihydroartemisinin piperacin, which is even more recently, which was recently more included in the guidelines, also has been tracking. We have seen a lot of cases of treatment failure. Now, if you see artesunate pyridoxine, that has minimal cases, especially in Nigeria, with no record of treatment failure, as of the time this data was done, right? Now, Antimalarial drug resistance or artemisinin partial resistance. What are we actually experiencing? Now, just to give a definition of terms to help us with our appreciation of the next couple of slides and our discussion tonight. Antimalarial drug resistance, we can see, is the ability of a parasite strain to survive and or multiply despite the administration of a drug given in doses equal to or higher than what is usually recommended, but within tolerance levels for the subject. So it's the ability of that parasite to survive, the strain of the parasite to survive and to continue to multiply despite the administration of a drug within its recommended treatment dose. Now, artemisinin partial resistance can be defined as delayed clearance. That's the word, keyword there, delayed clearance after treatment with a drug containing an artemisinin derivative of a parasite strain carrying a particular mutation or set of mutation. Now, treatment failure, which is not resistance, is the inability to clear parasites from a patient's blood and to prevent their recrudescence, that's relapse, recurrence of the asexual parasitemia of the same genotype. Now, we've talked about three things: antimalarial drug resistance, where the parasite survives and multiplies despite the use of the drug given. Then you have artemisinin partial resistance, where there is delayed clearance. There is clearance, but it is delayed. You know, when you give a drug containing an artemisinin derivative of a parasite strain carrying a mutation, right? Despite giving the drug within the same recommended dose, right? So with partial resistance, you have delayed clearance. With antimalarial drug resistance, you have the parasite thrives. It thrives, it survives despite giving the drug. Now, treatment failure is an inability to clear that parasite from the patient's blood and to prevent their recrudescence. Now, let me move on to treatment failure. Treatment failure is basically failure to clear that malaria parasitemia or to resolve clinical disease following treatment. Now, treatment failure is not necessarily antimalarial drug resistance. And there are several factors that lead to or that contribute to treatment failure. Incorrect dosing. I think we talked about it earlier today. Poor drug quality, non-compliance. We have, the studies from tonight showing, the challenges with multiple dosing and how that impacts on resistance, right? We talked about drug interaction earlier as well. So you see why I said, doctor has done a fantastic job. Poor or erratic absorption and misdiagnosis. These are things that can contribute to treatment failure. Now, management, you simply run your malaria microscopy, right? And confirm, whether the patient still is in a state of, active disease, right? Where you have parasitemia detected. Now, if it's positive, you treat the patient with an alternative ACT. So you don't repeat the same treatment. You place this patient on artemether lumefantrine, there's treatment failure, you cannot give another dose. That is not what is recommended, right? Now, partial resistance, we have seen those strains, and I think we've talked about it, we've talked about the PF-KELCH13 mutation, right? We have, the other strains that have been detected over time, right? So I don't want to really dwell too long on that. Now, what are the things that drive antimalarial resistance? We have four things. And out of these four drivers, two are really more prominent and more impactful because these are treatment-related antimalarial drivers to antimalarial resistance. We are talking about drug pressure. That is the use of one drug alone, right? If we look at the shelves of most pharmacies and hospitals in the country, you can see more than maybe 70 to 90% of the medications that are procured are simply one type or one ACT being used in those facilities. You have subtherapeutic drug level where the drug is exposed to a subtherapeutic drug level. And I mean, this is important. It's thought to be an important selective force in the spread of resistance. You have low adherence, which is, of course, incomplete treatment or suboptimal dosing of the drug. I remember Dr. earlier mentioning, how with artemether lumefantrine, right, you have to strictly follow the timing, right? Because of its rapid absorption and its rapid clearance from the system. So if you miss the timing, it means that the person will have suboptimal levels of the drug. And these are the things that contribute to resistance, to treatment failure as well. Reduced drug sensitivity, where parasites with mutations or parasites with resistance strains of parasites are being transmitted from one host to another host. So these are the 4 drivers. And I said there are 2 major ones that I want to really focus on, which is drug pressure and low adherence. These are the 2 major treatment-related drivers of anti-malarial resistance. Now, what is WHO doing, or what are they saying in terms of addressing the issue of anti-malarial drug resistance? The WHO has launched what we call a strategy to respond to anti-malarial drug resistance in Africa. This document is available online. You can check it if you want to read a little bit more. Now, the strategic objectives are threefold. Improve detection of resistance to enable timely response. That's one. Delay emergence of resistance to artemisinin and ACT partner drugs. And 3, limit the selection and spread of resistant parasites where resistance is confirmed. Effective implementation of this strategy depends on our understanding and addressing of the local drivers of resistance. Now, speaking to this, we just talked about the 4 drivers, right? And we talked about 2 major ones. We talked about the drug pressure and the low adherence. All right, so moving on. Now, what has WHO done, in terms of addressing this issue? 2 things: consolidated malaria guidelines. That's the first thing. That's the first strategy. The second strategy is to call for what we call multiple first-line treatment approach. I take it again: multiple first-line treatment approach. The first strategy, which is the consolidation of the malaria guidelines, right? We see that the 4th national treatment guidelines here in the country recognizes newer molecules, which is an advancement in terms of expanding options for recommendation in treatment of uncomplicated malaria. That's the first one. The second thing is to call for a multiple first-line approach. Now, this strategy is in a 4-pillar strategy. Okay, it's a 4-pillar strategy. Right, the first pillar is strengthening surveillance. The second pillar is optimizing the use of the diagnostics and therapeutics to reduce drug pressure. Pillar 3 is limiting the spread of resistant parasites. And the 4th pillar is stimulating research and innovation to leverage existing tools and develop new ones. Now, focusing on pillar 4, right, which I believe is where we have a role to play as pharmacists, right? One of the key recommendations there is identifying innovative approaches using the currently available drugs to delay the development and the spread of resistance. This is so critical, right? We talked about drug pressure, the fact that only one medication is being used actively. Now, WHO is saying that we should adopt an approach that encompasses all currently available drugs towards delaying development and spread of resistance. Now, what are those innovative strategies WHO has recommended? Multiple first-line treatments, the triple ACTs, rotation, or cycling. Now, all right. Thank you. Please, we'd like you to mute your mic. Thank you very much. Now, what are the multiple first-line therapies? The multiple first line is the use, and I would like us to just pay attention because this is the juice of this session, right? Multiple first line therapy is the use of 2 or more efficacious anti-malarial medicines in a population for the treatment of uncomplicated malaria, right? It is the use of 2 or more efficacious anti-malaria medicines in a population for treating malaria, uncomplicated malaria. Now, you can either use it simultaneously, you can use the drug simultaneously, which means that maybe you have a population of 100 Nigerian patients, right? You can say 50 of these patients will be administered with this ACT, and the remaining 50 at the same period of time will be also placed on another type of ACT, right? Or you can say, with the first 6 months of the year 2026, we're going to use this ACT. After we have used this, we're going to use a different ACT for the next 6 months. That is what we call rotation or cycling, right? Now, what's the rationale? Why? Why multiple first line? We want to be able to expose a specific parasite population to multiple agents, right? Because if this parasite is exposed to the same agents, the ability of that parasite to develop resistance is higher. So exposing that parasite to different ACTs will definitely prevent or delay the emergence or spread of drug-resistant parasites. I want us to take a minute thinking about the battle we're fighting, right? I can imagine, and I don't really pray this is the case, but I just can't imagine a case where we have a resistant strain like the ones we're seeing in Eastern Africa, here in Nigeria and West Africa, right? It means that the current options will be so limited, patients will be under threat of mortality because the available options won't even work. So we do not want to wait till that happens, which is why we have to be proactive. The use of the multiple first line is a deliberate intervention that must be adopted, not only in the public sector, but in the private sector. And we pharmacists, we are the front liners. We are the ones that are responsible for advocating and driving this change. Multiple first line requires that all anti-malaria drugs that are being used are effective. And all multiple first-line strategies used in Africa require a relative decrease in the use of artemether-lumefantrine. That is the truth, because this molecule, we need to preserve this molecule. We do not want this molecule to be rendered ineffective from treatment failure and from parasites developing resistance to it. It is so important to protect lumefantrine. We must keep our arsenals effective. Now, what are the considerations for MFTs in Nigeria? The emergence of independent artemisinin partial resistance is a strong consideration for us. The fact that there are resistant strains and we're seeing partial resistance trends in other African countries means that we must be on alert, right? We have to intensify surveillance, right? And proactive measures towards stemming this anti-malaria resistance from, progressing into Nigeria. Now, its potential for addressing the deployment of ACTs is one key consideration, considering the seasonal malaria chemo prevention implementation being an added attraction. Now, for us, we are driving multiple first line within this country to ensure that resistance doesn't develop and doesn't progress. That is the simple truth, and that is the reality for us. So going forward, we have to tell ourselves the truth that we can no longer stick to just one type. And another layer to this is, what has happened recently with the pediatric anti-malarial, segments, the delisted AL multiple dose dry suspension, dry powder for suspension, cases of instability from, the reconsidered suspension contribute to treatment failure and resistance. So the truth is, there is active surveillance going, and we must be proactive in adopting the multiple first line. So we're looking at ACTs, oral ACTs, still being the recommended treatment. The use of a single anti-malaria agent, right, is not recommended, right? So, even when a patient is placed on IV of this single agent, that cannot be the end. The patient must be followed up with an oral treatment of the ACTs, right? In Nigeria, again, the use of SP is restricted to pregnant women as intermittent preventive treatment, right? And chloroquine is still prohibited for the treatment of P-falciparum malaria, either as a single anti-malaria agent or in combination with other anti-malaria molecules. Now, what are the ACTs that have been selected for multiple first line? You have them on your screen. You have artemether-lumefantrine, artesunate amodiaquine, dihydroartemisinin, piperaquine, and pyronidine artesunate, which is Pyramax, which was included in the guidelines in 2022. Now, ladies and gentlemen, I want to introduce to you the latest ACT recommended for treatment of uncomplicated malaria, joining the battle against malaria, which is a formidable arsenal to be used in the multiple first-line therapy strategy. Now, this is Pyramax, the first and the only fixed-dose combination of pyrrolizine and artesunate for the treatment of uncomplicated P. falciparum and P. vivax malaria. And it's the latest ACT treatment that has been recommended by the WHO. Pyramax is three things: potent, reliable, and simple. Now, we talked about, its inclusion in the guidelines, 2022 by, in the WHO guidelines as a first-line therapy, and adopted in Nigeria in 2020. Now, how does Pyramax work? Because this is a new ACT, and we want our pharmacists to be, at the forefront of the knowledge about the molecule and how it works, right? Now, Pyramax, of course, like every other ACT, is a dual action ACT. Typically, with your ACTs, you have the rapid action ACT and then the long acting part. The rapid action ACT is artesunate, right, which provides a rapid, potent, and near immediate reduction of the parasite biomass. So it crashes the parasite biomass, right? While pyrrolizine, the new partner drug, as a long-acting partner, persists at therapeutic concentrations in the bloodstream long after artesunate is gone, maintaining that effectiveness over time. Now, I would like to introduce this molecule and this product, this Pyramax, as one of the latest clinical innovations, in the malaria space, because it's the first time, and I'm talking about the first time, that artesunate is combined with a partner drug in one single formulation. Typically, in the market and in the space, you usually have artesunate and pyrrolizine separated, still within the same pack, but in individual packing, right, or in individual dosings. But the first innovation of artesunate combined with another partner drug is here with Pyramax. Now, what is pyrrolizine, this new partner drug? It is a benzonafthridine antimalarial, which is a blood schizontecide agent, and has been in the world for over 5 decades. It's a WHO recommended ACT partner drug, effective against resistant malaria strains. Now, how does it work? It also has a dual mechanism of action, and I see this as a great advantage in targeting and reducing the risk of resistance. Now, it acts in two spots: the food vacuole and in the DNA of the parasite. In the food vacuole, typically the parasite breaks down hemoglobin into heme and converts that heme into hemozoin, and when hemozoin is released, that's what causes the clinical symptoms or the clinical presentations of malaria. Now, what pyrrolizine does is that it inhibits that full conversion of heme into an intermediate product we call hematine, which is then converted to hemozoin. So pyrrolizine in Pyramax forms a complex with hematine, and that complex is toxic to the parasite. So when it complexes with that hematine and accumulates in the food vacuole, it is toxic to the parasite and ends up leading to the death of the parasite. Also, because of the complex form, you also have free heme, which is left unconverted, which is also toxic, which leads to the death of the parasite. That is action at the food vacuole. Now, at the DNA level, it intercalates with the parasite's DNA, and this leads to an interruption in the ability of the parasites to replicate and leads to the development of an infected cell and ultimately the death of the parasite. So these two strategies are how pyrrolizine works, right? And really towards ensuring that risk of resistance is reduced, which makes it an effective agent against resistance. Now, speaking to this SAR, the structure activity relationship, this is the structure of pyrrolizine, and these are the different components that contribute to the effectiveness of pyrrolizine. And just to summarize it, we have the benzonafthridine core in the molecule, which is responsible for a strong antimalarial activity. We have the acridine-like scaffold down, the benzene rings down, that are responsible for that DNA intercalation potential. You have the aniline side chain that is responsible for reduced drug efflux, which is very critical in combating resistance with this parasite. Now, the basic amine groups also help with ensuring that the drug is available within the vacuole at sustained therapeutic concentrations, right? So what is the impact of this structure? Sustained intracellular concentrations in infected red blood cells, reduced cross-resistance, remember the aniline side chain, and also maintaining activity against resistant Plasmodium strains. So, ladies and gentlemen, pyrrolizine is a partner drug of choice, and it is one that has entered into the game as a new sheriff towards combating malaria. Pyramax is potent, reliable, and simple. Speaking to its potency, from Wanekam study, we see this drug having excellent cure rates that is sustained over time, with an expected fast parasite clearance of under 24 hours, which means that within a day, the patient is able to bounce back because the artesunate in the combination is able to reduce that parasite biomass, and the patient is able to recover and get back on their feet. Post-treatment protection is one valuable benefit, and we attribute this to the long half-life of pyrrolizine between 14 to 18 days. Now, from this Wanekam study, we saw that the clinical and parasitological response of Pyramax compared to artemether lumefantrine was significantly higher at 96.9%, even at 28 days after its use. Right? And even at 42 days, at day 42 of the use of this drug, it still had an effective clinical and parasitological response, right, of 81.5%. So we are saying that this drug remains in the body at sustained effective concentrations that can ensure that any incidence of relapse is effectively addressed, because this drug is available systemically, right, at effective concentrations even after several weeks from its use.
Thank you, Pharmacist
Speaking
Oladapo.
to,
Can you
okay,
please
okay.
just
To wrap up, yes, Thank you very much. I'll just speak to its efficacy in pediatrics, where we see that we have clearly, effective outcomes and better hematological response, because I remember that was something that came out in the first session. Now, speaking to reliability, we've talked about its potency. This was tested in a real-life scenario where Pyramax gave an effectiveness of 98.6 compared to artemether lumefantrine, which was below the 90% threshold by WHO. Pyramax is simple to use. It can be taken with or without food. It is just once a day, which offers compliance, which is a great advantage for a lot of us, right? For pediatrics, it comes as child-friendly granules. It is weight-based, so it's easy for us to use it, in both adults and children. The tablet comes as film-coated tablets, so there is no bitter taste that will impact on compliance. The granules can be taken with milk, with juice, very easy to use, and it's just once daily, right? In terms of safety, you have guaranteed safety. It does not prolong QTC interval, just like the other agents that we've seen, right? In terms of hepatic safety as well, Pyramax has that hepatic safety compared to DHAP, which is limited for just 2 treatments in a year. I don't think a lot of people even know that, right? So that's some of the advantages of Pyramax. Pyramax is potent, reliable, and simple. Thank you for your time.
Thank you very much. It is quite educating, quite enlightening. I'm sure we all enjoyed the webinar today. So we'll just have, how do we do it now? Do we just give 5 minutes for question and answers, or 10 minutes? Because time is really not on our side. It is 10:30. I will still have to go and rest and prepare for tomorrow's work. What? Sorry?
It's fine, then we round up.
I didn't get you.
I said 10 minutes is fine, then we round up.
Okay. So we have 10 minutes for question and answers. So if you have any questions, can you
Hello, Famade Tutu.
Yes, please.
I want to tell the company presenter that the form they dropped in the chat box requires access approval, something like that.
Okay, that has been
Okay.
rectified. Yes, that has been rectified. So you can try
Okay.
the link that has been reshared again.
Okay. Thank you.
All right.
So
Thank
please, the form. Let's fill the form, please. Thank
All right. So, do we have any questions or comments, contributions before we call it a day, or
Yes,
rather, call
my
it a
hand,
night?
my hand is up. I don't know if I can go on.
Okay. So, pharmacist.
Can I go?
Okay. Please go ahead. Ask the question.
Okay, thank you so much. I want to appreciate our both presenters very quickly. I have some series of questions, but I'll just take one or two
Okay.
because of the time. Now, my question is, when the first presenter was presenting, she made mention of ACT being contraindicated in first line therapy for pregnant women. I used to know that up until last year, I had an argument with a medical doctor who had prescribed ACT for a woman that was just a month or two pregnant. And when I met the medical doctor rather, and said this, that, the medical doctor clarified that ACT can actually be used as first line therapy now for pregnant women, that it was before that it was not, it was contraindicated. So I'd want the speaker to please look at that. And then also, finally, on the place of personalized medicine, will personalized medicine really work and pharmacogenomics really work on, on malaria in Nigeria, seeing that it is, let me use the word, pre-packed? It comes in six for those that are 80, 480. So whether you're 72 kg or 1 million kg, so far you're an adult, you would either take that six tablets or you take the ones that comes by 24, 4. So what is the fate of personalized medicine or pharmacogenomics as regards that in malaria handling, especially in Nigeria? Thank you. Sorry, my name is Pharmacist King David. I didn't introduce myself before asking the question.
Okay, I don't know if I can go ahead and respond. Now,
Yes,
I
you
think
can. Or should we take all the questions first?
All the questions,
okay.
let her respond to all, please. No time.
Okay. So any other person with any question? Any other
I have a
question?
I have a question. My hand is raised.
All right, please go ahead.
Okay, thank you very much. My name is Professor Chijoke Nwuche from the University of Port Harcourt. I thank you for the lectures. My question is directed to the sorry, before I bite my tongue. Please,
Pharmacy
I want to
biosis.
ask
Prof, thank you.
God bless you, sir. Thank you.
Symbiosis.
Sorry for that.
You.
Please, you made a statement about multiple first-line therapy, and you said that is advocated maybe first 6 months they will use so and so, the other 6 months you use the other one. I want a practical question, application in terms of in community practice now. Are you saying, in fact, I would like you to explain practically what you want to be done, because is it that we should just left for the policymakers? They will now say for the first 6 months, first line treatment is this, then the next 6 months, or what? Because at community level, people come in and go, for malaria treatment. And like we know, the first line treatment is the artemether lumefantrine. Are you now saying that maybe if 10 people come into a pharmacy, you recommend artemether lumefantrine, the next 10 people you recommend Paramax, the next one you recommend artesunate, I just want the practical application of this multiple first line therapy. I don't know whether my question is clear.
It's quite clear.
Very, very clear. Thank you so much, Prof.
Thank you.
Thank you.
Any other question? So I can just take everything. Okay, so Dr. Ayogo, please take the first question, then Dr. Oladapo, Pharmacist Oladapo, sorry, will take the second question. Let's have it like that now. Response, please. Thank you.
All right. Thank you, pharmacist. Okay, sorry, I've forgotten your name for your question. So, very quickly, till now, the recommended medication for treatment of malaria first trimester is still not ACT. ACT, like artemether-lumefantrine, is used second and third. It is still quinine and clindamycin that is recommended for first trimester. Till now, that is the WHO guideline. Maybe the physician maybe just want to give up, but second and third, first trimester is quinine
The
and
national guideline, not
clindamycin.
present.
That is if then if it is a prophylactic, it is still the IPC, intermittent preventive treatment. But if the patient or the pregnant mother is already symptomatic, is quinine. So that is my response for that. Then for personalized treatment, yes, that's artemether-lumefantrine or ACTs come pre-pack. It does not prevent or does not cancel the fact that it should be dosed by weighting. So if you calculate the dose and you should take more than 6, you buy 2 cards. And you can take 1.5, you can take 2 by weight. So it's not because it is 6-pack like that, then you maintain it. When we look at this and we start releasing publication and also start emphasizing on this, then you find out that by weight, then the medication you can have, that one that comes 24, it gives you liberty to either take 3 or 4 or 2 according to the weight. That it comes pre-pack will not make you to increase or decrease it, because for some they may not take up to that 24 even when they're adult. For some they will need more. So that is my response for that one when it comes to personalize, not blanket everybody, whether your weight permits or not, you take 4 or you take 6. All right, thank you.
Thank you, Ma. Pharmacist Oladapo, the second question, your response, please.
Okay, thank you so much. Thank you so much. And I see, someone made a comment that it's a practical question. Now, in terms of the deployment of the multiple first line, it's a programmatic approach, right? There are 2 manners or 2 ways of deploying that strategy. Is either you do simultaneous or in a rotational or cyclical manner, which means that for cyclical or rotational, you use a certain group of ACT, right? Maybe within a window. Then after a while, you switch up to other first-line ACTs, to ensure that the parasite, because that's really the goal, the parasite shouldn't be exposed to just one type of ACT where it can build resistance, right? So it's continuous exposure with the different patients coming in, the same parasite genome or the same parasite strain is exposed to different ACTs. So maybe a practical way or approach is having different multiple first lines or having different first line agents available as access at a typical pharmacy or hospital. Maybe that's the first place to start with, right? And ensuring that patients are able to access the different ACTs, the different first lines. We talked about them: artemether-lumefantrine, artesunate pyronidine, dihydroartemisinin piperacin, and of course artesunate amodiaquine. So they are available. Now, in terms of deployment, it can be, you can develop what works for your system, right? So you can decide that it's simultaneous, where you are deploying at the same time, maybe within a space of a period of 6 months, you're going to use these same agents to you're going to use it as an arsenal for the patients that you're seeing within this period of 6 months, and then maybe you switch up later, or you use a group and you switch to another group of ACTs. So that would be my best way of recommending that. I can definitely have a conversation with you after the call, so we don't take too much time to see how we can effectively deploy it, right? But at the back of our mind, the first thing is, let's have all these ACTs available within our system, because the main challenge is the fact that the existing ACT that is mostly used, which is AL, is what most people have access to. Is what they know. They don't know the newer molecules. They don't know, and a lot of them, even when they have treatment failure, they still end up going back to use other brands of the same molecule, right? In those scenarios, the patient shouldn't use the same molecule. They should use a different molecule, right? So our recommendation is, and based on this strategy, is that all these molecules should first be available. Then you can organize it either in a simultaneous approach or in a rotational approach, where the groups can be used in the same period of time within the group of patients, or you run a cyclical program where different ACTs can be used, in a cyclical manner, right, within your establishment or your pharmacy or your hospital. I hope this is able to address the question. Thank you.
Yeah. Thank you
Yeah,
very
thank you. Maybe I'll have to have a chat with you, private chat with you. Thank you very much.
Yes,
Thank
yes,
you
ma'am.
very
I
much.
would like to get your contact through the attendance link. Thank you so much, ma'am.
All right, well.
Okay.
Thank
Good
you very
evening.
much.
Good evening, Prof. Good evening, Sipan. As well, just to add, so the multiple first line approach, first thing, first of all, from WHO, is a call for diversification. So we want to diversify, trying to ensure that pressure is not already, as we today, they selected pressure on some ACTs. There's already a selected pressure. So the first approach is the call for that particular strategy is call for diversification. How community pharmacists, how procurement pharmacists, doctors can now diversify away from the already selected pressure which is happening on AL. That's one. Now, number two is now the mathematical model for the approach is calling for simultaneous use. Originally, there is an ongoing research. There is an ongoing research at the moment to bring in a particular drug that have one artemisinin molecule and two partner drug molecule. Is a combination medication that should have one artemisinin and two partner drug molecules. The essence is to also expose the parasite to multiple partner drug molecules to ensure that they didn't gain that resistance. So that is the essence. So, but now, the already ACTs we have in the market is having an artemisinin and a partner drug. Example, artemether and lumenfantrine, artesunate and pyronaridine. So because they're having a partner drug and the artemisinin part, so if we want to follow that simultaneous approach, it means that you have to give the patient either AL. Upon completion of the AL, the patient have to resume artesunate pyronaridine to ensure that simultaneous approach so that the parasitemia can be exposed to different partner drug at the same time. Or we do a rotational. The rotational, you are doing either for the first, the rotational model can either be a model of either
quarter to 11, so please, what to stop now?
Be the rotational model.
Please,
but the direction WHO is going is to see how we can have just one.
Please stop and let's round up, please. Time is not on our side. It's almost 11 p.m. Please. It's almost 11 p.m. We need to call it a day. I thank you very much for your contribution. Thank you. God bless you. And I also thank everybody for attending this webinar. It's been very educating. It's been very enlightening. It's new things being unfolded. And we really appreciate everybody and our facilitators. I say a big thank you to you, both of you, for this very good lecture webinar. Thank you and God bless you. To round up, please, can we have Dr. Mumini? Can you please give us the
National
closing?
Chairman of SIPAM, please. Dr. Morin Wafo will give the vote
Oh,
of
she's
thanks.
online. Okay, okay. So please, can she, Dr. Moriniwafo? Sorry, I didn't know you're still online. Can you please
Good
give us
evening.
a vote of thanks and closing prayer, please? Thank you.
Good evening, everyone. I hope I'm audible. I just want to start to appreciate all of us that have been here all through up to this time in the night. Thank you so much. I want to start by thanking Farmers Symbiosis. You are wonderful. Frankly speaking, I just came across this pyramas just a few weeks ago. Frankly speaking, I didn't know what it is until I went through Google. So thank you for exposing this beautiful molecule to us this evening. I want to start by thanking my dear lecturer, Dr. Ebere Ayok, for a wonderful lecture. I'm not surprised. You did a wonderful job. Thank you so much. And the second speaker, Fama Olata, but thank you so much. Wow, even the moderator, you are wonderful. I want to thank my NEC members who are here present. Dr. Biajulo, Dr. Issa, Dr. Bello, Dr. Kwanta, and our dear Education Committee Chairman, Fami Fama Moma. Thank you so much for joining us. And I pray that other companies will come on board to really showcase their products to our members and also to educators. I can end by saying that now we can, now we must, to drive away malaria in our communities. Thank you so much and enjoy your night rest.
Thank you, Ma. So I want to really appreciate everybody for staying up until this time as well. And thank you to our lecturers and thank you to everybody, all protocols duly observed. So can we now call it a day?
Yes.
Or rather, let's call it a night.
Nice.
Thank you. So
Thank you.
we can all, I appreciate you. So when next we have another webinar, we'll let you know. Thank you and God bless.
Thank you.
Good
Good
night,
night.
everybody.
Night.
You will leave my room. Far out to go.